afternoon, and welcome to this Opioids Overdose Brain Injury Series sponsored by the AdCare Institute of Maine and the BIA Maine chapter. Today's topic is Introduction to Opioid Misuse and Treatment. The BIA Maine chapter gratefully acknowledges partial support for this training series for the Administration for Community Living, the U.S. Department of Health and Human Services, and the Maine Department of Health and Human Services. To ask a question, please type it in the questions and answers box of your control panel. At the conclusion of the presentation, I will read as many of these as possible to our presenter. Our presenter today is Dr. Chrystal Fullen, a clinical neuropsychologist serving the Department of Psychiatry, Neurology, and Trauma Surgery at the University of Arkansas for Medical Sciences. In her role, she has developed and co-directs a multi-tiered cognitive rehabilitation program at the hospital to foster interdisciplinary inpatient and outpatient rehabilitation of cognitive dysfunction, primarily in a TBI population, which also includes behavioral management of post-injury psychiatric symptoms, family psychoeducation to improve recovery, and brief psychotherapy to improve adjustment to injury outcomes. Welcome, Chrystal.
Good morning, everybody. Thank you, Peggy, for that kind introduction. So we are going to be spending 90 minutes together this morning. So please take any breaks that you guys might need as we go along. The topic today is traumatic brain injury and opioid use disorder, and really just digging into some of the trends in those two disorders, disease processes, and then, of course, the treatment and what that looks like together. So I'm going to move my slide along here, and hopefully someone will let me know if the screen isn't moving. Here are some announcements. Thank you, Patricia. Here are some announcements from the Brain Injury Association of America. Just going to leave that on there for a second. And then we also have some disclosures through AdCare, who are helping us with this webinar today. Okay. And then I always think it's nice if you're doing a, presentation with someone that you don't know to learn about them a little bit. So I wanted to share a little bit more about me. As Peggy said, my name is Chrystal. I'm a neuropsychologist. I actually work at two large facilities in the state of Arkansas. I work at the University of Arkansas for Medical Sciences, and then also at Baptist Health Rehabilitation Institute. In both of those settings, I work predominantly with inpatient populations, so people who are newly injured, typically with some variety of acquired brain injury. And I do a combination of cognitive and neuropsychological assessment for those folks, as well as cognitive rehabilitation to sort of help rehabilitate some of the symptoms that they're experiencing as a result of their brain injury. A big part of what I've been hired to do is not just patient care, but also program development and consultation. And so what that looks like is really looking for ways to develop programming for people who have acquired brain injuries and other disorder processes in order to sort of improve their experience and really just improve their quality of life. So that's a little bit about what I do. That picture over there is me and my dog. His name is Apollo. He is a 155-pound Great Dane, and I always take him with me anytime I go to any community event. And we went to a MS walk. I think this was last year's walk together, and he's always a fan favorite. I'm sorry that I don't have him here today, but he's always a fan favorite. All right, so now that introductions are out of the way, let's get into the objectives for today. So these were probably listed when you signed up for this webinar. So I'm just going to run through them quickly. Some of the goals here is really to start by defining traumatic brain injury, defining opioid use disorder, looking at risk factors for both TBI and opioid use disorder, or OUD, explaining the connection between TBI and OUD and what that looks like, especially its impact on health and well-being when people have the comorbid TBI and OUD. Then I want us to kind of switch to talking about prevention opportunities, treatment strategies, things that we might consider for treatment, and then really just looking at the challenges of TBI and OUD, both separately and then again together, and then really just encouraging small ways that we can increase awareness about comorbid TBI and OUD and improve advocacy efforts in the state of Maine and then beyond as well. So without further ado, I am going to get us started on the TBI 101 part. So really just an introduction to what traumatic brain injury is. So we'll look at the definition, how folks classify traumatic brain injury, what are some of those core symptoms, and what are the treatments that people should consider for patients with TBI. So we're going to start here together. Okay. So the definition for traumatic brain injury, if you had to Google, you're going to see a million different things, right? There's a lot of people who are describing traumatic brain injury in a different way. I have a favorite diagnosis. It's there on your screen under definition. It's taken from the CDC and the Department of Defense, sort of like a combo definition. And what they say a TBI is a disruption in the normal function of the brain that can be caused by a bump, blow, or jolt to the head, or a penetrating head injury with new onset or worsening of at least one of the following. So alteration of mental status, so things like confusion, neurologic deficits, so things like not being able to walk or not being able to speak, and then intracranial lesions, so things like bleeding in the brain. So a simple way to define a TBI is a blow to the head from an external force. There are really two types of TBI when we're thinking about TBI: open traumatic brain injuries, or also known as open head injuries, closed traumatic brain injuries, or closed head injuries. An open head injury sounds like what it is. It is when something enters the skull and actually pierces the brain. So that can usually result from wounds like a gunshot, which is a high velocity wound and is associated with increased death. And then there are low velocity wounds like someone being stabbed in the head with a knife. That's a low velocity wound, also super dangerous. In fact, with open head injuries or open TBIs, you have an increased risk of mortality broadly in comparison to closed head injuries, simply because when that skull is exposed and your brain tissue is exposed, you're at an increased risk for infection. And so that can be kind of tough to manage sometimes, because even a tiny little infection getting into your brain can wreak serious havoc from a neurological perspective. We also have closed head injuries or closed TBIs. This is when you have strong external forces that are injuring the brain. So this would happen in the case of something like a fall from a high height, or a car accident where the brain is sort of cushioned in layers of tissue, layers of cerebral spinal fluid, and then the skull, right? But if there is a lot of force played on the brain, especially with something like a car accident, it usually exceeds the capabilities of the body to protect the brain as an organ. And there can be bruising, there can be bumping and jolting. Little tiny parts of neurons deep inside the brain can tear, and so you can have some pretty serious injuries. A fun fact about falls and traumatic brain injury is that a significant height for a TBI is 4 feet. So that's how far you have to fall, 4 feet, to have a significant traumatic brain injury. So essentially, people can fall from standing, just fall over from standing, and that is, a high enough height to cause a significant injury. All right, so I want to talk about injury processes for a second, because this is important when we're considering how symptoms persist in brain injury and what treatment looks like, and how the medical field has changed to adapt to treatment for traumatic brain injury. So we have what we call primary and secondary injury mechanisms in TBI. Primary injury mechanisms is everything that happens at the point of contact. So whether that's a closed or an open head injury, that point of impact, that's when primary injury mechanism begins. Immediately, you have disruption of how the brain works, right? You can have bruising, you can have diffuse axonal injury. That's what I was mentioning earlier, where neurons are tearing and shearing as a result of the external force that happens in something like, let's say, a rollover motor vehicle accident. And you can also have hemorrhage or bleeding. So that's happening immediately at the point of contact, or impact rather, and then a couple of seconds to minutes after the fact. Secondary injury mechanisms is everything that happens after that initial impact, right? So these are hours to days later. So you can have ongoing electrical changes in the brain, chemical changes in the brain, neurotransmitter changes. People can have swelling. They can have changes to intracranial pressure. The pressure in everyone's brain at sort of like a normal point, so like for all of us right now, is a very, very highly balanced system. And anytime that pressure changes just a little bit, it can cause a lot of very, very serious issues. It can cause the brain to shift off its midline, and it can also cause the brain to herniate down and out through spaces in the skull. So those secondary injury mechanisms really need to be managed. And what we found is that, how many persistent symptoms people continue to experience years after their brain injury are most related to those secondary injury processes. So acute treatment, when people are coming into the hospital and they're getting stabilized, we want to manage that primary injury, that initial bleeding, that initial bruising, and then we want to do everything we can to minimize the development and how much secondary injury mechanisms this person is experiencing. And then I also just want to note that, when we're thinking about all these ways that we can save people after TBI, that's great, but also traumatic brain injury is a pretty new field. It wasn't until about the 1970s that there were, enough technology and enough change in the medical field that people could even be saved after something like a severe TBI. So it's still a pretty new field. It's only about 50 years old. That seems like a long time, but it's not a long time in the medical field at all. And it's also not a long time for us to look at longitudinal research about what people's quality of life is like with good treatment following a TBI. So there's a lot that we still don't know. And you'll see that is true as well for opioid use disorder in a little while. I also want to say that initially, when people had things like traumatic brain injury, they were classified in the psychiatric population, like a TBI. If someone had really serious persistent symptoms after the fact, they would be hospitalized really long term in psychiatric hospitals. This was back in the day. But I think you can probably see from just our conversation so far that, traumatic brain injury is not a psychiatric process. It's a neurological process. And so for a long time, people were not well treated as a result of how they were being classified. So let's look at severity of TBI. So no two brain injuries are equal. If you have two patients with a brain injury, you may see some similarities, but because of the unique things that make us who we are, when we have an injury to our brain, personalities can change in different ways, cognitive abilities, motor abilities, all those different things can change in different ways. Even if you have the same level of injury in the same area of your brain, it can look different. And at the same time, there are a range of severities that people experience with TBI too. So all the way from mild to severe. Now, when we're thinking about and talking about mild traumatic brain injury, that is the same thing as a concussion. So I know a lot of times people say, well, it's just a concussion. That's the same thing as a mild traumatic brain injury. So when we are trying to define how serious a brain injury is, we can use a bunch of different criteria. We can use any one of the criteria you see listed on your screen on its own, as well as a combination of those things together. So we can use something like a Glasgow Coma scale, which is a 3-part scale that is given to people at the scene of something like an accident, so usually given by EMS. And that 3-part scale looks at people's motor response. So can they follow a motor command like raise your right arm? We're looking at verbal response. Can people intelligibly answer questions through speech, like say where they are, who they are, and their name accurately? And then the last part of that scale is your eye opening. So are you able to open your eyes and intentionally direct your gaze per an instruction? So you can get a score on that 3-part scale as low as 3. That scale starts at 3. All the way up to 15. So if you're scoring between 13 to 15, that's a mild TBI. If you're scoring 9 to 12, that's a moderate. And then, of course, if you're scoring in that lowest part of the range, 3 to 8, that's a severe TBI. We also look at loss of consciousness, whether someone's lost consciousness or not helps us tell how serious the brain injury is. We also look at alteration of consciousness. Are people altered? Are they in a confused state, and for how long? We look at PTA, or post-traumatic amnesia. This is when, after an injury, your brain's ability to make new memories is paused. The reason for that, if you think back to those secondary injury mechanisms and you're looking at things like swelling and biochemical changes and ongoing bleeding, those types of things, that is getting in the way of the brain's ability to act normally, to process information normally. The brain is in DEFCON 5 mode. It's trying to keep someone alive because all of our automatic processes in the body, like breathing and heart rate and all those types of things, blood pressure, is also regulated by parts of the brain. And so those things are prioritized, not making memories. So it's not uncommon for people who have, let's say, a severe traumatic brain injury to be in the hospital and not remember how they got there, not remember their accident, not be able to recognize well-known people, have no idea about what the doctors have been telling them, and that can last for longer than a week. And then last but not least, we have imaging. So if someone gets a CT or an MRI, are we seeing findings on that CT or MRI? Usually for a mild traumatic brain injury or concussion, CT and MRI are normal. Whereas with moderate and severe TBI, we typically do see changes on structural imaging. I will say that there is one caveat to that. If you ever hear of a complicated mild traumatic brain injury, that means that the criteria you see for mild is all consistent with the exception of imaging. Sometimes we can have someone who, doesn't lose consciousness, their GCS is 15, there's no alterations, they're not confused, but they have a tiny little brain bleed somewhere that is noted on imaging. We call that a complicated mild TBI. So definitely not a concussion anymore, but something that falls between mild and moderate when we're being, thoughtful about what recovery might look like. So when we are in this mild range right here, we are expecting people to be back to baseline, back to pre-injury levels of functioning around 3 months max following their injury. If people have persistent changes after that fact, it's usually because of other factors that got in the way of their ability to fully recover. When we're here to these moderate severe ranges, we're expecting that even a year to 2 years after the injury, people may not fully recover. Some people do, but there are many people who don't fully recover and they continue to have persistent symptoms over time. Okay, so now that we know a little bit of the science around TBI, let's look at some of the causes and the impact of TBI. So one of the leading causes of traumatic brain injury is a fall. So almost half of people who have a traumatic brain injury have one because of a fall. I will say that there are certain age ranges that are more or less at risk for TBI because of this major cause. And so if you think about the tail ends of the age spectrum, really, really young children, and then older adults, when coordination is maybe less, precise, when people have more balance problems, are a little more wobbly, they're more at risk for falls and therefore more at risk for traumatic brain injury. About 15% of people have TBIs because they're being struck by or against an object. And then about 14% because of traffic accidents or motor vehicle accidents. And so you're kind of seeing that the core, reasons people have TBIs are mostly because of falls and violence and car accidents, I think is a nice way to kind of summarize that. Interestingly, despite the fact that this age range isn't at one of the tail ends of the age spectrum, the people who have the most TBIs are not these at-risk young, very, very young kids or older adults, but actually 16 to 24-year-olds. 16 to 24-year-olds have the most traumatic brain injuries. And I think if you look at that screen and you're seeing some of the causes, you can kind of tell, well, what happens between 16 to 24? People start driving, right? People start drinking alcohol. People might be put in positions where they are exposed to more risky behaviors and risky settings as you're sort of coming out of adolescence and into young adulthood. So that's the age range where people are having the most TBIs. Essentially, the impact of this on society is that TBI is one of the leading causes of death and disability in this country. The country pays, millions and billions in healthcare costs associated with brain injury. Of course, for people who are caregivers of a loved one who has suffered a brain injury, there's a high risk of burden because of the fact that people are having persistent symptoms for such a long time, and there are so many places in the country that still don't have the care that those people need to really recover well from their injuries. And then, of course, it's always one of these things where you have this one really terrible thing happen to you, and you're still at risk for all these other terrible things. And so when you do have a TBI, that unfortunately increases your risk for a lot of other things, which we'll talk about in a little while. Sort of major scale statistics here in this country, there are about 586 hospitalizations every day for traumatic brain injury and approximately 190 deaths per day. On average, the kind of standard in the country is around 55 to 60% survival from moderate to severe TBI right now. Okay, I wanted to talk a little bit about some statistics in Maine. So let's start with annual statistics. So in 2024, approximately 5,000 Mainers sustained a TBI due to a couple of different categories. We're seeing the same trends: falls, motor vehicle accidents, and then sports. So of course, with many sports, especially things like football and then combat sports, so like boxing, MMA, that type of thing, people are at an increased risk for the development of a TBI. And then there's some unique issues associated with statistics in Maine. And some of these issues I actually found from a needs assessment that was written in 2010. So it might be a little late or a little old, rather. That's 15 years ago now. But broadly, uneven resources are present in the state. So places where there are more or less resources available, there are limited services. So there aren't as many people who are specialized in training to support people with the nuanced sort of picture of symptoms after traumatic brain injury. And then really just not enough rehab facilities and things like that for neurological change. And then also just parts of the state being more accessible or more rural or less rural also makes a big difference. And then really, TBI has been a public health issue in Maine for a while. There are a lot of hospitalizations associated with TBI, a lot of discharges from the hospital associated with TBI, and then unfortunately a high number of folks who pass away because of a brain injury and have ongoing and prolonged disability, can't go back to work, can't go back to the things that they were doing before their brain injury as a result of persistent symptoms. What I do want to say is some of these numbers might be a little off, and that's because in some studies, people are looking at brain injury broadly, right? And in other studies, they're looking at just TBI. And so some of these numbers might actually be lower than they are because they're not including other acquired brain injuries, or they are including other acquired brain injuries. So let's talk about that for a second. What is acquired brain injury? So if we back all the way up, acquired brain injury is sort of an umbrella term for anything that happens after birth that's not congenital, right? So something that happens to you unexpectedly after birth. So TBI could be one of them. So that's under the umbrella of acquired brain injury. Then there are also other types of brain injury that can happen too. So things like infections, strokes, lack of oxygen, which we call hypoxia, or complete loss of oxygen, which we call anoxia. People can have neurological diseases that are degenerative and continue to take away from the brain over time. People can have drowning, assault, or suicide attempts that result in lack of or loss of oxygen, so anoxia or hypoxia as well. Okay. So brain injury symptoms. So we're talking about brain injury symptoms here, really talking about things that can happen as a result of any acquired brain injury with a primary focus on TBI. So this can be for any acquired brain injury. So because the brain is really something that this organ essentially that does everything for the whole body, right? It is controlling movement, it's controlling those autonomic functions, it's controlling thought processes, emotions, all those different types of things. When that organ is injured, you can see symptoms in any one of the things the brain is involved in. So what we really think about it as is a multi-system injury because the brain is in charge of so much. And so we can see so many different systems being impacted as a result of a TBI. So we can see sensory changes like, sensitivity to noise, sensitivity to light. We can see people struggling with sensations like taste and smell. Many people will experience prolonged fatigue after a brain injury, as well as headache. And headache can persist for up to or past 3 months. 3 months is usually the typical period of time that people's headaches remit, but people can have headaches for a while after a brain injury. People can have motor problems, so they can have hemiparesis or weakness on one side of the body. They can have trouble with coordination or balance problems. They can have trouble with speech, like the motor aspect of speech, the ability to move your mouth in a certain way. People have cognitive problems, of course, and cognitive problems are cited as one of the most debilitating sets of symptoms after a brain injury because of the impact they have on our ability to sort of engage with society, have relationships, go to work, volunteer, those types of things. And so usually where people are injured, if someone, let's say, has an injury or a hit to their right temporal lobe, they might have cognitive problems that are associated with what the right temporal lobe is in charge of from a cognitive perspective. And one of the things the right temporal lobe does is visual memory. So they might have visual memory changes as a result of that injury. But regardless of where someone has experienced a head injury, that primary injury mechanism, those secondary injury processes play a role too. And so most people with a brain injury, even a stroke, even hypoxia, anoxia, will struggle with things like attention, they'll struggle with processing speed, and they might struggle with some higher order cognitive functions like executive functioning and memory, just because it's supported by so many other cognitive abilities. For example, to remember, you have to be able to pay attention, you have to be able to learn, you have to be able to store that memory in an organized way and then go back and retrieve it. So if you have an attention problem, that's probably going to show up in your memory as well. People, of course, experience psychological and behavioral changes as a result of TBI and other acquired brain injuries. They may experience adjustment disorder just because of everything that they have to kind of deal with after that injury. But then they might also experience depression and anxiety or have worsening psychological difficulties following a TBI if they were previously diagnosed with one as well. There's a lot of comorbid PTSD and acute stress disorder following TBI simply because of the nature of what causes these injuries. So especially with vehicle accidents and assault, you can imagine that people can not only have a brain injury, but then also experience PTSD as a result of what happened to them. And then last but not least, some of those behavioral changes, people are going to have changes in sometimes their eating and food preferences. They might have sleep disturbances. They are at an increased risk for substance use. They may have more impulsivity, and they have what we call anosognosia, which is a decreased ability to really see and understand the extent of changes and symptoms that they have experienced because of their injury. So really reduced awareness. And if you think about it, that can be really, really challenging. If someone has, cognitive and psychological and, let's say, sensory changes because of their brain injury, and they're not aware of that, that's really going to decrease how much they're going to want to even get any treatment or understand, some of the things that they might be at risk for. So very, very tricky symptom. So because we have this, array of symptoms that someone can experience because of a brain injury, we need to have multifaceted treatment that can target that array. So of course, as we've been speaking, we've kind of gone through a couple of different things already that people might be exposed to as a result of the brain injury. The first one being intensive care, taken to the hospital. They might have something like neurosurgery to stabilize those primary and secondary injury processes. They may get involved with a physician team called PM&R, or physical medicine and rehabilitation. These are doctors who specialize in managing rehabilitation of things like polytrauma, so multiple injuries, particularly brain injuries and spinal cord injuries. When people are in the hospital and then when they leave, if they're fortunate enough to go to acute rehab or long-term rehab, they'll also get involved with folks like me, as well as allied health, PT, OT, speech therapy, to help with psychological and other symptoms and to rehab those symptoms as the brain is starting to heal. If we can pair our rehab with the brain's neurological processes, that natural healing process, you can kind of have a boost of abilities because you're having two things working on the same problem at the same time. And then, of course, there are outpatient services we want to always prioritize for people with brain injury. So more allied health, psychology, psychiatry, social work, and even complementary medicine. We want to make sure we have opportunities for people to do things like acupuncture, yoga, animal-assisted therapy, really music therapy, anything that can help alleviate some of those symptoms that they're experiencing to improve quality of life and get them back to the lives that they were living or want to be living, right? Back to work, back to volunteering, back to spending time with family and friends in a meaningful way. All right, so I'm going to transition us now to opioid use disorder, or OUD. So we're going to look at that kind of 101 type intro again. I'm just going to have a sip of my tea. Okay, so same thing here. The plan is look at the definition, some of the statistics, really take a deep dive into some of the symptoms that people experience in the treatment. And when we're done with that, we'll combine the two together and talk about things that we can do moving forward. So with opioid use disorder, let's start with substance use disorder. So as you know, with the new DSM, we sort of have this umbrella term, kind of like acquired brain injury. We have substance use disorder, and then depending on the substance that you use, your that substance use disorder is further specified or clarified. So I want to, take a moment here to just sort of acknowledge that with substance use disorder, we have a lot of research, specifically for, certain types of very, very well-known substances like alcohol, right? We have a lot of research about what works and what doesn't. One of the things that we still, I think, don't fully appreciate, or maybe some of us appreciate it, but it's really kind of hard to almost put into words and to put into treatment action. And that's that substance use disorder is very, very complex. It really is. It is incredibly complicated. And our understanding of why people get to a point where they're misusing a substance continuously is still a little bit flawed, because I think it's just like no two brain injuries are alike. The reasons people use and don't use substances are very, very different and unique to them. And so it's a very complex thing. So what is a substance use disorder? Well, it is a complex psychiatric disorder. It was previously sort of termed and thought of as addiction. We don't use that term as often anymore, but really speaks to sort of someone having a persistent use of a substance that might be a little bit more uncontrolled, and that results in negative things for them, yet they continue to use that substance despite those negative, consequences. The cause, like we were saying, is really unknown. There are some things that people have said, hey, in the research, this is definitely something that can increase someone's risk of developing a substance use disorder. Those things are family history of substance use, adverse childhood experiences, or ACEs. Of course, the number of ACEs you have, your risk goes up. any early exposure to substance use. So if you're seeing people use substances when you're very young, frequently in the home, that can also increase your risk. Any comorbid or pre-existing mental health conditions. And then, of course, traumatic brain injury. We said this earlier, behavioral changes, behavioral symptoms associated with TBI is impulsivity, is increased risk or increased use of substances. So there are a couple of key features associated with substance use disorder on the biological level. Of course, the first one is intoxication. So experiencing sort of like a drug-induced pleasurable effect from a substance. Tolerance, where you're using that substance over time and the dose that you started with is not enough to give you that feel-good feeling, and you're needing to use more of that substance in order to kind of search for that feeling. And then withdrawal. So when you're not using that substance and that substance is sort of like lifespan in the body is leaving the body, you have withdrawal symptoms, and those withdrawal symptoms tend to make you want to use and seek out that substance again. So there are 4 categories required for the diagnosis of a substance use disorder. The first being here impaired control. And so really just that inability to sort of, stop yourself from using despite the fact that there are negative consequences. Social problems, which are some of those negative consequences, issues at work, issues with family. Dangerous use, so putting yourself in really risky situations in order to be able to use a substance. And then last but not least, that drug effect, which has to do with some of these key features here, that, tolerance, withdrawal, intoxication, vicious cycle. So before we get into OUD specifically, I want to talk about the opioid crisis, as it's been kind of termed. I think that, if you've, anyone who's turned on a TV, looked at the news or anything like that has probably read about this, heard about this. There's Hulu shows, there's documentaries. There's so many things about the opioid crisis that I think is important to kind of talk about for a minute here today. So how did this happen? So how the story goes that opioid sort of crisis happened is that, back in the 80s, there was a big push by healthcare advocates that doctors did more for patients presenting with chronic pain. Essentially in the 80s, people were saying, hey, people with these pain conditions, they're being undertreated. They're not necessarily getting what they need. And so there was this push for people to, prescribe more medications that they knew were helpful in pain management, right? So this was happening around the same time. Drug companies are, doing their thing, advertising and things like that, pain medications like opioids and how effective they could be. And so these two things happening at the same time, doctors trying to prescribe more medication to be more helpful with pain. And then at a certain point, in the early 90s and early 2000s, we start seeing problems arise, right? We're starting to see people who are prescribed opioid medications dying from overdose, sometimes accidental overdose, probably often accidental overdose, to the point that in about 2015, over 17,000 people died in the United States from prescription opioid overdose. Prescription opioid overdose. That is a lot of people. So this really prompted a public health emergency. So by the early 2000s, there was a lot of targeting of prescription opioids and like this push to not prescribe that medication or prescribe it very carefully or very judiciously. And then in 2010, because what would happen was people who were prescribed opioids and could no longer get it from their doctors, they would actually try to get, whatever they could on the streets. And they would get things like heroin and start using that instead because it was cheaper and more readily available. So then things like heroin got targeted. And then over time, fentanyl got targeted because people started using that as well to sort of get that opioid back in their system. So initially, right, this shift, we need more help for people with pain, and then this problem, and then okay, we sort of overcorrected and now we have this crisis where we're really needing to decrease use of these medications and target these street drugs that are resulting in these very scary overdoses. So of course, all of this led to lots of policy changes, guidelines for how people were prescribing pain management, a push to prescribe things that are non-opioids in order to help with pain. A push for behavioral interventions like certain types of therapies and counseling to manage pain. And then also a sort of spotlight on really looking at what else people were prescribed. Like, okay, you might be prescribing this medication, but they might be, prescribed a sedative from a psychiatrist too. So how can we always be doing sort of medication consolidation so we can really be looking at what else people are taking so we're not increasing their risk of overdose because they're taking other sedating medications as well. And so even though there's been the opioid crisis, there's been tons of lawsuits, there's been so many different initiatives, which is wonderful that we have these initiatives now. There is not a lot known about subgroups that are at increased risk for OUD and the adverse consequences if we think about things happening at the same time. Unfortunately, nothing happens in a vacuum, nothing happens in a silo, right? And so I'm speaking today specifically about traumatic brain injury. That's a subgroup of people at increased risk for OUD and vice versa. And so there's been a lot of push to understand OUD specifically, but not necessarily these subgroups that are at risk and how we can potentially target that. And so today's talk is one helpful step in the right direction. So specifically OUD. So this is substance use disorder with a primary substance use being an opioid. There are a couple of different opioids. We've all heard of them: oxycodone, hydrocodone, morphine, commonly prescribed for significant pain conditions still to this day. And the reason they're commonly prescribed is because opioids work. They very, very effectively manage pain. There are also some illegal substances I already mentioned, the shift where people were prescribed opioids, now they can't get them. So now they're using street drugs like heroin. That's a type of opioid, as well as synthetic medications like fentanyl, or synthetic drugs rather. So of course, with any substance use disorder, we're seeing those 4 categories that we have to have and a problematic use pattern across a 12-month period of time. So that would define opioid use disorder: problematic use of opioids for, about a year with all of these negative consequences happening. There are some unique differences when it comes to opioid use disorder and some other drugs. And so I want to kind of talk about that for a second. One of the biggest ones, and I think this is super striking, is that with opioids, you can develop a physical dependence to that drug in as little as 4 weeks. And what's 4 weeks? 4 weeks is a month, right? How often do people get prescribed a controlled substance for just 1 month? Okay, I'm going to give you this, but I'm only giving it to you for a month because it's not a safe medication to be using long term. So here's, 30 pills, 1 a day to help you with that pain, right? So often, controlled substances are prescribed for 1 month only. And unfortunately, with opioids, that's as long as someone needs to develop a physical dependence. There are also significant withdrawal symptoms. And those withdrawal symptoms include a bunch of different things. Pain, of course, because now the medication is leaving your system and it's so efficiently and effectively controls and manages pain. And then a bunch of different gastrointestinal things: cramps, diarrhea, people get nauseous, they'll vomit, people have a lot of anxiety, they'll have restlessness, they won't be able to sleep, they'll have chills. So very, very, very significant withdrawal symptoms that will result in cravings and, of course, that increased motivation to continue to use the drug as well. Let me see my screen here. Okay. So I got this picture from the American Psychiatric Association to kind of look at the withdrawal timeline together. Also such a quick turnaround. So if you look here at last dose, right? You could be taking a short-acting opioid, kind of stays in the body, works for about 12 hours, or a long-acting opioid that might stay and work in the body for 30 hours. But right away, as soon as that short-acting stops, your symptoms begin and peak within 3 days, where you're experiencing these really, really uncomfortable symptoms and intense, intense drug cravings to take another opioid, right? And one thing that I need to say here as well is that we're going to have another presentation. Here's a plug. We're going to have another presentation about some of the more science behind what opioids do specifically to the brain and how they work. But one of the effects of opioids is not just pain control, but also it does induce a sense of calm, and people do have, slightly improved mood as well as a result of taking an opioid medication. This is what's described and what is working on certain neurotransmitters in the brain. And so not only are people sort of taking it for pain, but over time, they can sort of be this experience where they're recognizing that they're feeling better. They're more calm, they're more chilled out, they're more relaxed. And so that's another reason why that drug craving is going to be there for a push to use, not just pain control, but that feeling of calm as well. Okay, let's talk about some statistics with regards to opioid use disorder. So about 20% of people broadly who are prescribed pain medication develop an addiction to them. That's 1 in 5. That is a lot of people. And that is one of the, I think, statistics that really should be highly publicized, because there is so much stigma. I think people think, oh my gosh, how could you get addicted to that, right? People think that. But it is so easy to be prescribed a medication that is super effective, unwittingly, develop a physical dependence that you didn't even realize was happening, and then have that dependence and really be seeking that because of how badly you feel because of those withdrawal symptoms. So really, to reduce stigma, think about this statistic. And then with other substances, many people with OUD turn to things like heroin due to tolerance and availability, right? They become so tolerant of opioids, there's not enough that can even be prescribed if their doctors are even willing to increase doses, which doctors really aren't willing to do as much anymore. And so they'll turn to other drugs in order to continue to feel that feeling of calm, feeling of pain management. Apparently, up to 40%, almost half of the people who are heroin users started using opioids, and most of them prescription opioids. 40%, that's huge. What's the impact here? Well, per the CDC, over 100,000 deaths due to drug overdose occurred in 2022. And approximately 75% were related to opioids. And so not just prescriptions anymore, that's been curbed a lot, but also heroin and fentanyl. And what happens, the reason people are at such a risk for overdose with these drugs is because of that calm that I was mentioning, that controlled pain, all those controlled pain gateways and things like that. Opioids actually slow breathing. They slow breathing levels to pretty dangerous rates. So when you're taking too much, whether on purpose because you really feel badly and you feel like your one pill isn't doing it or 2 pills aren't doing it, or whether it's accidental, people will overdose because they'll stop breathing. So let's look at the overall impact of opioid use disorder. So of course it impacts people's health, right? There is a high risk of overdose. People who are taking opioids tend to have chronic health problems, especially if they're taking that long-term, things like liver damage, cardiovascular problems. People can also be at risk for infectious disease, especially if they do transition to other drugs and how they take those drugs, HIV, hepatitis C, those types of things. Of course, people can also have mental health difficulties or worsen pre-existing mental health difficulties, anxiety, depression, and PTSD being the most commonly associated with opioid use disorder. There's also, of course, that social impact on people's lives. We know this because of substance use disorder, but people will have problems with relationships. They may be unemployed or become unemployed as a result of their withdrawal symptoms, their changes in behavior, risky behavior, and so on. Many people will just miss work a lot and eventually lose their jobs because of that. And then, of course, there are also legal issues that come up because of risky use and risk taking to get other drugs that can simulate the experience. And then, of course, there are economic impacts on society as well. Healthcare costs, of course, being a big one, workforce losses, and then criminal justice expenses because of that, risky use and behavior. Okay. All right. I'm assuming my slides are still moving along. Okay. Yeah, someone would tell me. Excellent. Thank you. All right. So with treatment for OUD, so because there's been this push and we had the opioid crisis, there has been a nice, spotlight on opioid use disorder and what we can do about it. So we do have some evidence-based treatments for OUD, which is good. One of the biggest groups of treatments are MOUDs, which are medications for opioid use disorder. So we have things like methadone, which most people are familiar with, naltrexone, buprenorphine, which are things like Suboxone and Sublocade. And we have lots of clinics. So sometimes you'll have clinics like methadone clinics. Typically with methadone, you're getting one dose of medication per day. So you're going to the clinic often, which can be difficult for some people to be able to do. But for some of those methadone clinics, they also have counseling embedded into that service. They may have social work embedded into that service that can allow people resources. Many people with substance use disorder, including OUD, will end up becoming unhoused. They'll lose their jobs. They, won't have any money for things like food. There'll be malnutrition. There'll be all these other things. So having these clinics with these social services as well as counseling can help really target a more holistic treatment to help get people into a better situation to decrease risk of use. So all of these MOUDs, what they essentially do is they're designed to reduce withdrawal symptoms. So the symptoms we spoke about earlier, they're really designed, not to give people any kind of like calm or happy feeling, but they are there to help with, reduce withdrawal symptoms, reduce cravings, and reduce that experience of pain to a degree so that people aren't, really pushed to use opioids again. So very effective, very helpful, not always available, unfortunately. So I also want to talk a little bit about overdose and medications for overdose. So this is being sort of highly publicized. At the other day in the hospital, we had people, giving out little kits that you could, carry with you. I was visiting New York City probably a couple of months ago as well, and I saw signs for it all over the subway, like what to do if you suspect a fentanyl overdose. So in some places, they are doing a lot of sort of visibility to create awareness, a lot of commercials, a lot of free kits that people can carry with them. And so with overdose, you're having medications like naloxone, which can quickly reverse the impact of opioids on the body. How this works is it really blocks the drug effect at the brain receptor that it's impacting, which can very quickly improve breathing and not slow that continue to let that breathing be super slow, which is one of the effects of the drugs. And so when it comes to overdose medications that are super quick, we have things that are nasal sprays. You can kind of spray really quickly. Things that are injectables, you can inject someone really quickly. The only problem with some of these drugs is they can also cause vomiting, which can cause a choking risk for people as well. And so something people have to be very sort of aware of. Most people are like overdosing, maybe lying on their back. You kind of have to turn them. So there are a lot of easy ways to teach people how to do this, but there are a lot of risks as well. So something to kind of consider too when you're giving education to people is that high vomiting risk after taking one of these overdose prevention medications. Okay, let's transition to talking about traumatic brain injury and opioid use disorder. So two of my favorite resources for anything brain injury is the BIAA and then also the MSKTC. That is the Model Systems Toolkit. They both have great resources about brain injury that I readily use all the time. And one of the fact pages on the MSKTC website actually talks about traumatic brain injury and opioid use, and up to 70% of people with TBI are actually prescribed opioids following their injury. And it's more common for people who have more severe traumatic brain injury, but the issue is that half of people with TBI experience chronic pain, and that's usually because of polytraumas. We spoke about that earlier. If you imagine someone being in a really bad car accident where they sustain a really severe brain injury, it stands to reason that they may have broken some bones, have some other bruises, maybe have a really bad neck injury. And so these are people who are going to their doctors. They have a, cacophony of symptoms because of their brain injury. And on top of that, they have pain. They may even have post-TBI headache as well. And so, they could get prescribed opioids pretty easily. So it's well established that people with brain injury are at an increased risk for substance use, but unfortunately, a lot of them are still being prescribed opioids after they're injured. So almost a quarter, up to a quarter almost, of brain injury survivors develop OUD. That's a huge, huge number. There are a couple of other studies that were mentioned as well. For example, people with TBI are 10 times more likely to die from accidental poisoning from either things like alcohol, things like opioids than the general population. And there is evidence that people who are prescribed short-acting or long-acting opioids, were more likely to attempt suicide. So lots of data that shows that opioids are not a good idea in the brain injury population. And we'll talk a little bit about why as we go along. Let me see. Okay, so let's talk first about risk factors associated with TBI and OUD. So what are the risks? We spoke about this a little bit for sustaining a TBI. Let's go over them again. So we have some physical and environmental factors to consider first. So age, right? There are agers that are preferentially more likely to be impacted or likely to sustain a TBI. There are also high-risk activities. Certain sports are a big one, but any sort of risky behavior, things like maybe, not wearing a helmet when you go on a four-wheeler, something like that. And then, of course, if you've already had a brain injury, you're at risk for another one. There are also some behavioral and social factors. Of course, alcohol and drug use can put you at risk for sustaining a brain injury. If you are already a person that tends to be a little more impulsive, tends to be a little bit more, reckless, maybe you have a risk-taking personality, you like to, live life on the edge, as they say, that can put you at risk for a brain injury. And then, of course, there are medical factors too, right? So any chronic health conditions, unfortunately, can put you at risk, including pain, chronic pain, and then mental health disorders as well, can put you at risk for developing or sustaining a TBI. What are those risks, again, for OUD? Well, we have medical factors too. So if people have an injury, if they're recovering from a surgery, they may have pain, right? And so they're at risk for developing an OUD because they're also there's a high chance that they're going to get prescribed one of those medications in order to manage that pain. Of course, people have mental health problems too that can put them at risk for the development of any substance use disorder, including OUD. And then again, we're seeing ACEs or adverse childhood experiences that can preferentially put people at risk for developing any substance use disorder. Of course, prescription practices are a huge risk here with OUD, any overprescription of this medication. And, again, opioids do work well, and some people are able to take them and take them carefully and not have, not develop a use disorder or misuse. But what ends up happening is that there isn't adequate monitoring when people are taking these medications. You can't have a 1 month follow-up if in 4 weeks, you're already sort of at the point where you have physical dependence. You're going to need like weekly follow-ups if you're prescribed a medication like that. And sometimes that's very, very difficult in some places to do. Social determinants of health, also a big risk for OUD. So people who are living in poverty, who are unemployed, who don't have access to certain resources, maybe live in rural communities, all of those things are going to increase risk. And oh my goodness, every time I present, I see one spelling mistake and it makes me crazy, guys. I spell communities wrong. How did I not pick up on that? Okay. And then let's talk about overlapping risk, right? So what is the overlapping risk between these two commonly comorbid conditions? First being pain management, right? If you experience polytrauma, if you have chronic pain, you're at risk for both. And if you have one or the other, it's going to preferentially increase your risk for the other. Cognitive and emotional difficulties, if you're experiencing cognitive impairment, if you have mental health conditions, if you have a substance use history, that's going to increase your risk. And then socioeconomic factors, again, unemployment. But one of the biggest ones is limited access to care. When people have limited access to care, they don't know what they don't know. They don't know that they're at an increased risk for this other thing. They don't know that some of the things that they are doing could preferentially put them at risk for having a TBI or having an opioid use disorder. So I want to take a moment to just kind of run through a very likely, commonly occurring patient scenario. So let's put all these things together, right? So you can imagine a 34-year-old male, let's say he has a motor vehicle accident, and maybe he fractures his pelvis. Very painful, very painful. He has to have a couple of ortho surgeries to fix that fracture and stabilize his pelvis so that he can walk. And he's prescribed oxycodone after the procedures. After about 3 months, his doctor's like, I'm not prescribing you that medication anymore. You know what? Like, you can't take it anymore. It's really bad for you. I'm going to send you to pain management. So if you need that medication, they will manage it. They will monitor you. So he goes to pain management, gets another prescription, and his prescription is increased because it's not working at the initial dose that his original physician prescribed. And he starts having withdrawal symptoms when he attempts to decrease use, because even his pain management team is like, okay, we can do this for so long. We have this counselor here. They're trying to do everything right. But those withdrawal symptoms, they just really get to him. And, one day overuses his medication. He's a little unbalanced. He's a little wobbly. He's on the back porch enjoying the evening, and he falls off and sustains a brain injury. The next day, he's found by family, and EMS comes, take him to the hospital, and they see that he has bleeding in both parts of his frontal lobe. Now, he has a TBI and opioid use. Opioid, at least at this point, it's not been a year, but problematic opioid use. So very, very common scenario where someone who is misusing a substance can experience a brain injury. So if we're connecting the two here, we're seeing that, TBIs can result in things like chronic pain. And as a result, people can be, more easily prescribed opioids. TBIs also result in neurological changes, psychological symptoms, sleep disturbance, economic challenges, and all of these things preferentially people at risk for using a substance like opioids. And then there's a lot of stigma associated with brain injury. Again, like I said, it wasn't until recently that people with brain injuries were categorized as being neurologically injured versus having a psychiatric disorder that was causing them to maybe behave in a way that was different from how they used to be before their injuries. A lot of people don't understand why people with brain injuries limp or slur their words or have problems with memory, and they attribute it to things that are out of this person's control. There's also a lack of support because we just don't have the services nationwide that people with brain injuries need. Similar with opioid use disorder, we know that it can result in that respiratory depression. And when you don't have enough oxygen going to your brain, that's an acquired brain injury in and of itself. That is hypoxia. right? Also, when you're taking opioids, it can result in things like being more sedated, you can be more drowsy, and you can have falls, just like our patient scenario. When you're driving, you can have reduced reaction time, putting you more at an increased risk for a motor vehicle accident. There are riskier behaviors, increased exposure to things like violence, being unhoused, having unsafe living conditions, mental health difficulties, all contributing to people wanting to use again. And then, of course, long-term neurological changes. You're using any drug with any kind of regularity that is acting on your neurotransmitter system, acting on your brain, it is going to impact your cognition. It is going to impact your mood and cause an effect there as well. Okay, so when we have comorbid TBI and OUD, that's going to have a pretty big impact on someone's health or well-being, right? If you have a TBI and you're using opioids and you're using them repeatedly, it's going to cause worsening memory function, decreased decision-making ability, increased impulse control issues, as well as increased risk or active symptoms of depression, anxiety, PTSD, and any kind of adjustment disorder that you might still be working through. It's going to put you at risk for, unfortunately, because we don't have enough awareness, but increased stigma. There's going to be reduced social support for most people, always limited access to care and patient education about what they're experiencing. Risk of repeated head injury, which will make the situation so much worse. And then, of course, because if you're having memory problems and you're having decision-making issues because of a brain injury and using opioids, you're absolutely going to be at a greater risk of overdose. You might not remember what you've taken earlier on in the day to manage your pain. So let's move into the last part of our presentation, really talking about treatment and prevention. And unfortunately, this is the shortest part of the presentation because we don't have enough treatment and prevention programs for comorbid TBI and OUD, which is why we're all here today. So when it comes to sort of like pie in the sky goals, we really need a combination treatment model that is able to treat opioid use disorder with any other co-occurring condition. Opioid use disorder and major depression, opioid use disorder and PTSD, opioid use disorder and TBI, so that you can reduce the risk of OUD and reduce the risk of traumatic brain injury and how they are going to co-occur and impact one another. So thinking about this ideal treatment approach, I'll say first that there is a limited evidence base already for any comorbid TBI and OUD process. There are a couple of initiatives in the nation where people have tried to create programming. In fact, when we were here in our state, when we were applying for an opioid-related grant, and we also came up with a program. We didn't get the grant, but we are up for another one that we're looking into, and sort of tried to design this program with a bunch of different specialties that may interplay with both TBI and OUD to try to come up with a combination therapy that could target everything all at once. It's a hard thing to do. And so because there are only a couple of programs here and there, we don't have a good evidence base for a program designed for both, to treating both at the same time. What we need to consider is individualized treatment planning, a treatment that considers barriers to care and recovery, a treatment that targets all of the factors that increase risk for the other thing, right? If you have both TBI and OUD at the same time, there are things that are happening with both of those processes that are increasing ongoing use for the other thing or ongoing injury or reduced neurological recovery. And so making sure that we're doubling down on those factors. For example, if you have a TBI and you're struggling with memory problems and memory problems are putting you at an increased risk for overdose and increased risk for misuse of an opioid that you've been prescribed, we need to double down on that memory problem because all of those other things like overdose could put you at risk for hypoxia. So another brain injury could put you at risk while you're taking that and you're having these, decreased respiration and calm feelings and, not being coordinated as well can also put you at risk for another injury too, right? So we need to double down on those factors. So we need to have a treatment approach that encompasses a couple of different things. Encompasses things like cog rehab for cognition, alternative pain management strategies, medication for OUD, because we know that's evidence-based, things like CBT for depression and anxiety, so cognitive behavioral therapy. Increase social support, because social support tends to decrease when someone has a substance use disorder because of those consequences. And then resources for adjustment disorders and lots of education, because people don't know what they don't know. That's a huge, huge factor in any treatment. So let's go through some of these that might be a little bit new together just quickly, and then we'll move into some questions. So cognitive rehabilitation. So some people know about cog rehab, some don't. Cognitive rehabilitation sounds like it is. It's a type of therapy that's targeted at rehabilitating cognitive functioning. After a brain injury, this is important because cognitive problems are huge after a TBI. So what we're doing in cog rehab is we're focusing on functional gains. Okay, if you're struggling to pay attention or remember, how can we work on giving you skills to target or combat that so that in your day-to-day life, you're able to do more. You're able to go to the grocery store independently, pay attention when you're there, remember what you need to get when you go to the store and not get home and be like, oh my goodness, I forgot the milk. Those types of things. So we're targeting cognitive domains. We're using manualized treatments. Usually there's a nice strong evidence base for cog rehab in the literature, lots of practice guidelines for traumatic brain injury, other acquired brain injuries, and specifics. So if someone has specifically a memory problem after a traumatic brain injury, there are nice practice guidelines for that. And the good thing about cog rehab or cognitive rehabilitation is it can be offered in group or individual settings. So it can be nicely woven into any OUD programming, even if it is group programming, let's say at like a methadone clinic. We also need to increase alternative pain management, right? So of course, they're asking physicians to, not prescribe opioids, but there's a ton of other things we can do as well. There's physical therapy, there's complementary alternative medicine or CAM, so things like acupuncture, yoga, those types of things. Of course, we have counseling. We know this is helpful. Education, we know that that is helpful. Knowledge is power. It helps people understand how things work. It can help them better make good decisions around what they're doing. And then there are also types of evidence-based psychotherapy models like cognitive behavioral therapy for chronic pain, which people find very, very helpful as well. And so if we're doing all of these things at the same time, we're improving cognition and functioning, we're decreasing how much pain people are experiencing. And if we add to that something like CBT, it's also got a very nice, strong evidence-based, we can use it, with groups, we can use it in individual settings. We can do lots of sessions. We can do limited sessions. We can adapt it if people have cognitive impairment. You don't need to have, people, you don't need to exclude people from psychotherapy if they're experiencing cognitive impairment. In fact, there are studies of CBT that are successful in patients struggling with depression who are diagnosed with dementia. So that's proof right there that CBT can be used to help people who have neurological changes. So if now you're targeting cognition, you're targeting pain in different ways, you're targeting those emotional symptoms that are coming up like depression and anxiety, and you're doing something like MOUDs, you really are catching a whole bunch of things that you need to really make a good combination treatment. Also want to give a shout out to something like Narcotics Anonymous and increasing people's ability to sort of attend something like that. These are well-established support groups. So even if you have a support group at a facility where you're running some of these programs, this can be really, really helpful. The biggest reason for it is because it's free. So that immediately makes it so that people who don't have health insurance don't have to worry. They can go, they can attend. It's readily available. I know they use 12-step models. Some people like that, some people don't. But ultimately, the research shows that when someone is involved in AA or NA, abstinence levels are twice as high with attendance there versus other programs. And that's a lot. That's really, really good. So with everything, there are issues, and there are some issues with treatment too, right? And so things that you need to kind of consider preferentially if you are creating programming for comorbid TBI and OUD or comorbid OUD anything is available resources. What resources do you already have at hand that you can use? Because it might not be all of the ones we just reviewed together. And then cost. Is there any way you can reduce cost here? You know, even if you put aside insurance and you just think about people who have insurance, some people, even with insurance, can't afford the copays to attend a program that asks you to come, you know, once a week or even twice a month because copays are so high. The other thing is making sure that we're prioritizing treatment planning, you know, for individuals and keeping that spirit true, because sometimes you can have clashing treatment plans. You know, if someone is at one facility getting treatment for OUD and at another facility getting treatment for TBI, they might be getting information that is clashing, which can, you know, cancel out some important aspects of treatment. So kind of bringing that treatment together is really key. And then also making sure you're not prioritizing some symptoms over others. So a lot of times I'll have a patient who'll have a substance use disorder and be recovering from a brain injury and will want to place them in a facility that can give them their best option. And the facility will say, nope, no, we can't take them. You have to treat the substance use first. And then you call the substance use place and they're like, nope, can't take them. You got to treat the brain injury first. Again, kind of the proof being in the pudding that we really need something bimodal that can treat both things at the same time. Because there is a lack of evidence base, anybody who is treating folks who have comorbid OUD with anything else, adding to the evidence base if you're able to in any way, even with case studies, can be so helpful to guide other people in what they're doing. And then really kind of working on increasing social support. A nice way to do that is including things like Narcotics Anonymous and those types of services so that people are connected to communities. Another quick patient scenario, something that's very, very likely to be able to happen, right? Got a TBI survivor. He's got chronic pain from a motor vehicle accident that he sustained where he got the, you know, the brain injury. And he's prescribed an opioid medication because he has chronic pain. And he has a lot of symptoms associated with his TBI. He's got some cognitive changes, some behavioral changes. And so he forgets when he takes his medication, sometimes takes a double dose and quickly develops a tolerance very, very quickly to the medication and needs more and more and more of that medication. He experiences some euphoria, which helps with his mood. His mood is lower since his brain injury, and that also increases his desire to use. So despite information about the dangers, he continues to use. He's got some poor impulse control issues. He's got, you know, these memory problems that causing him to take double doses and things like that. And slowly but surely, you know, he develops an opioid use disorder. Very, very common, very, very likely. So how can we prevent these things from happening? I feel like there are three nice broad categories that we can work on. The first one being community outreach and services. You know, I think it's so important to create community-facing materials, advertisements, flyers, things that people can see about the risks of opioid use disorder, the risks of comorbid opioid use disorder and brain injury, just things that can help people learn about what's out there. And then I think patient symposiums are really nice. There's so many conferences for professionals. What about conferences for patients? We have a lot of these more and more now for different populations, but what about a patient symposium that people can come to if they have a comorbid, you know, substance use issue and a brain injury, where they can come and learn about the resources that are available to them. And then any community initiatives, especially with neighborhood partners, if you do have a local NA or you do have a place that does cog rehab that people can, you know, self-refer to and things like that, what about partnering with those people to create outreach, to create education, to create awareness for people who have comorbid TBI and OUD? Bottom line, we need more services. Then with early education as well, we want to begin education for substance use and brain injury way early. We want people who've maybe experienced both to be able to go to things like schools and talk about the risks for both of these things. And then last but not least, we know that prescription practices are huge. It has helped the opioid use crisis tremendously by changing the way that people prescribe these medications, but we also need to work more to decrease stigma and then develop these nuanced combination treatments in order to really kind of help continue to do better. Awareness and advocacy, I think, always begins with education. So training healthcare providers, training caregivers, having programs where caregivers learn what providers know can be so, so helpful. And then really increasing that peer support presence. There's a lot of peer support inherent in substance use disorder where, especially if you're in NA or AA, you can have a sponsor. We need to do the same thing for brain injury as well, so that people have peers who've experienced both so that they can really help guide. And then, of course, we need these individual treatment plans with counseling, with increased check-ins, with plans for pain management should that arise. If people are being prescribed opioids, we want to make sure they're not being prescribed any other sedating medications that can increase the risk of overdose. And then we really want to make sure that if someone does have a TBI history, we're kind of maybe not prescribing them opioids just because we know a quarter of people will go on to develop OUD, right? A quarter of people. And then if people have a brain injury and they're prescribed opioid use disorder, if they're at risk for risky activity already because of impulsivity and reduced, awareness of things and so on. So really making sure we're being very, very cautious about how we're monitoring when someone has a brain injury versus not, and they're being prescribed an opioid. So to summarize, TBI and OUD, of course, preferentially increase the risk for one another. Both are major public health issues. There is unfortunately limited research, for how we can treat both at the same time. And treatment, when we do get really good at creating a comorbid treatment, it needs to be individualized and it needs to be multifaceted. And that prevention and how we can sort of prevent this from happening, these two things from co-occurring, is really going to begin with awareness initiatives. All right. Thank you so much. I'm going to stop here and see if anyone has any questions that I might be able to answer.
Hi, thank you so much, Dr. Fullen. Yes, we do have a question from Elsie Freeman. The question was, what data is there for long-term sequela of moderate injury with MRI changes, i.e. psychiatric or cognitive symptoms 10 to 15 years later?
Really good question. So the way that it used to go is that when people had a moderate to severe TBI, people believed that you only had approximately 12 to 24 months for neurological recovery, meaning specifically that the brain would recover for about 2 years. And in that span of time, because the brain is recovering on its own, symptoms are decreasing slowly. But then at that 24-month mark, you're kind of set. And people believed at that point that the only additional gains people would make would be from external rehabilitation that could help them, maybe not necessarily improve at a neurological level, but improve at a functional level, right? So maybe my memory's not great, but I can figure out different ways to organize and structure my life that I can still be successful at work, volunteering, and so on. However, newer research is showing that there is neurological gains after moderate to severe TBI up to 5 years post-injury, which is huge. It's so huge. It's a two-sided coin, right? If you have 5 years of neurological injury, you have 5 years to help get better, which is great. But also you have 5 years of very chronic symptoms that are also going to be ongoing. And so there's more time for neurological recovery than we ever suspected before. But there is still longitudinal data up to 15 years post-brain injury, regardless of when neurological recovery stops, that shows that people with moderate to severe TBI, while they might not make neurological gains, they can make functional gains. You have people going back to work 10 years later. It's a long time, but there can still be gains, functional gains with continued rehabilitation and other services.
Great, thank you, Dr. Fullen. At this time, we do not have any additional questions in the chat. So with that,
You do have some in the one just
oh,
came through, Peggy. From Brad, what are forms of cognitive rehabilitation for SUD if you don't have a TBI but have suffered from long-term substance use?
That is a great question. Right now, there aren't any specific evidence-based treatments for cog rehab that is targeted substance use disorder specifically. However, there are some broad, like span, general manualized treatments for cog rehab that don't specify a specific injury. For example, they're not saying, hey, you have cognitive changes because of TBI, you have cognitive changes because of MS, you have cognitive changes because of a stroke. They're just sort of broadband cognitive strategies that can be used when people are experiencing cognitive impairment for any reason. One of the ones that I like is the ACRM manual, or the American Congress for Rehabilitation Medicine. They have a nice manual that talks about cog rehab more broadly, strategies and techniques that can be taught. So if you do have substance use disorder and you have experienced cognitive decline as a result of that, you can make use of some of those compensatory strategies to continue to improve day-to-day functioning.
thank you, Dr. Fullen. It looks like we do have one or two more people that have questions. If you have questions, if you can put it in the questions and answers window, we can be able to see those more quickly for you.
And if it's okay, I'll just quickly mention I'm Patty. I'm a neuro resource facilitator here in Maine, working specifically with brain injury and underserved populations, so individuals with substance use disorder, marginally housed, mental health diagnoses, incarcerated populations. So if you have further questions about this information, please sign up for the future webinars that we have with Dr. Fullen, but also feel free to reach out. I'll put my information in the chat box as well, because we do have some pilot programs going on here in Maine and some specific resources here in Maine as well. So just pipe that in while people are typing.
Thank you so much, Patty, for that. Dr. Fullen, we did have another question come in for that from Mary. What are the neurocognitive changes that occur after an overdose?
Wow, that's a good question, and it depends, right? So if someone has an overdose and they survive that overdose, and they lost oxygen for a while or lost complete oxygen for a period of time, what is typically going to happen, if we think about that as being very isolated, and I say that because let's say someone's been using for 2 years, that could have caused neurological issues as well, right? So if we forget about that and we just focus on post-overdose, where there was loss of oxygen, especially in the OUD setting, what most people struggle with from a neurological perspective after that is memory and executive functioning. They can have very, very dense memory problems, such that they can very, very much struggle to remember new information after something like anoxia, loss of oxygen completely to the brain. They can also have a fair bit of executive functioning difficulties. Uniquely with anoxia and hypoxia, people tend to struggle with executive functioning that can sometimes impact their like social decision making and social cues and awareness and things of that nature as well. So, that's sort of like the more classic textbook, what we're experiencing, what people will experience from hypoxia and anoxia can look different on individual bases, but that's sort of globally what you might expect. Oh, and one more thing I actually want to add. Sorry. One more thing that people have really badly with hypoxia and anoxia is reduced motivation, like really bad amotivation, that can be very, very challenging to treat, unfortunately. You often find that their caregivers are very, very like, oh my gosh, let's sign them up for everything. And it's very, very hard to get them motivated. And it's a symptom that's very, they can't control it, just like any other symptom. Very, very difficult to treat.
Great. Thank you very much, Dr. Fullen, for your presentation today. And if you are here with us again, we hope that you do consider coming to the next series and our next session scheduled for next month. I also want to say thank you to AdCare Institute of Maine for hosting our webinar today. And I want to say thank you to everyone for joining us today. And we hope that you have a great day.